So we're covering grief. And with grief, what is y'all interpretation of grief?
Grief is a reaction to a tragic event.
Or extreme loss of how you respond to a tragedy
And
or the process.
Yeah.
It's the coping mechanism or whatever.
What do loss mean to you all? What do loss mean to you all?
Death.
To be
That
separated.
you don't have it
To be
anymore.
separated,
That it's not
not
there
to
anymore.
have anymore.
Okay. You say to be what?
Separated from something.
Right. Loss can come in many forms. A lot of people, when they think of loss, they think of more so death, but loss definitely can come in many forms. You all will deal with patients who experience loss. Loss can be an amputation. Hey, where I no longer have my legs, or I no longer have my arms. I no longer have my support system. Loss comes in many forms. And with loss, patients do experience grief. They definitely experience grief. It talks about different types of grief. Um, grief can be normal. Some grief is anticipatory grief, and that is grief that is experienced before the expected loss of someone or something. And that's more so when a doctor tell a patient, hey, you got about 3 months to live. Maybe the patient end up expiring after 2 months opposed to the 3 months. And prolonged grief, previously known as complicated grief, and that will be grief that lasts longer than 6 months. And it actually can affect the patient holistically. And disenfranchised grief is grief related to a relationship that does not coincide with what is considered by society to be recognized or justified loss. And some people grieve, some people, they go through grief for a very long period of time. That they grieve for a long period of time. And typically, different books say different things, but the average person shouldn't grieve longer than a year or two. That's what's typically said. It's normal for us to grieve when we experience loss, but when it starts affecting us functionally, you know, you are really taking your loss hard. You're really taking your loss hard. And it just points out we all have our way of grieving, and there are different things that can affect how we interpret grief. There are things that can affect how we actually grieve, and that could be our culture. Our culture can impact how we grieve. Our support system can impact how we grieve. So some people just feel like, oh, girl, I know you cry every day, you missing your legs or whatever. I know you just cry every day, your mama did. If my mama was dead, I cry every day. You know, those types of things where it can affect the way that we should perceive grief, the way that we should actually perceive loss. So there are people who can influence even how we express our grief. You know, you have some cultures who raise men, you better not show no signs of pain. You better not be sitting there crying. Men don't cry. You know, those types of things where it affects how I actually grieve. I'm scared to cry in front of you. And it talks about Dr. Elizabeth Kubler-Ross. She is a psychiatrist. She worked with patients who were on their deathbed, and she studied the dying process. And with the dying process, she came up with the 5 stages of grief. With the 5 stages of grief that Dr. Elizabeth Kubler-Ross came up with, it's not to the point that she feel all patients will experience all 5 stages of grief. And it's not a specific order of experiencing, the 5 stages of grief. The 5 stages of grief is denial, anger, bargaining, depression, and acceptance. You have some patients who can actually go to the hospital. Once they go to the hospital, doctor like, hey, you have stage 4 cancer. There's nothing we can do. You have about 3 months to live. And patients show that they're in denial. What? I got 3 months to live. This is the reason why I don't come to St. John. I'm going to Detroit receiving where I'm going to get better results. And the patient go to receiving and doctor like, hey, you know what? You have stage 4 cancer and actually you have about 45 days to live. So some patients become angry. Some individuals become angry. I know my God ain't about to let me die. I know my God ain't about to let me. I hate my God. I'm not supposed to die like this. You know, because everybody who end up finding out, hey, you about to die, everybody don't want to die. Everybody do not want to die. But there are people who do want to die. At first, I used to think ain't nobody want to die until I started working in healthcare to see patients. There are people who want to die. Some people, they 80, they 90. They like, all my family dead. All my friends dead. I don't got nobody. I may as well go to die. You know, so there are some people who want to die, but there are some people who definitely died, who definitely got killed where they weren't ready to go. And it talks about bargaining. And even with the 5 stages of grief, patient experience denial, patient experience anger, some patients become depressed. And signs of depression are, hey, they become withdrawn. They don't want to be bothered. I'm not going to do my hair no more. I ain't brushing my teeth. I ain't eating or I'm overeating. Signs of depression. And that's typically because reality is set in that, hey, yeah, you about to go. And bargaining, it comes with talking to God, talking to your higher being. Hey, God, nobody in my family ever graduated from high school. My first grandchild about to graduate from high school. God, you got to let me live to see my first grandchild graduate from high school. That's all I want before I go. Just let me live to see my first grandchild graduate from high school. And people typically get what they ask for. They end up seeing a grandchild graduate from high school and they end up expiring right after.
Not my grandma. Oh, I'm like sorry, y'all. I didn't know I was off mute.
It's okay. And acceptance is where the person comes to terms. Yeah, I'm about to go. You know, I love you all. You know, it's just a part of life. At some point, we all go. That's where acceptance kick in. You all probably will see examples on the exam where you need to point out whether the scenarios are showing that this patient is in denial, angry, bargaining, depression, or the individual is showing you that now they have come to terms and they accept that they're about to expire. And I think just living life, one of the sad truths is that we all will die. And it's kind of funny because my grandmother just died in April from COVID. And even before she died, one of my messages to her, because she kind of had this thinking, you know, I'm going to be here when Judgment Day comes. I'm going to be here when Judgment Day comes. I'm going to be that special person, that type of thing. And in some aspects, it's like, okay, Jason, you're a little mean, but I used to got to be direct with my grandma. Like, grandma, just like many families and many of their friends have came and they have went before us, that will be the story of our family too. We will come and we will go just like those families who have came before us. And it's just a part of life. Death is a natural part of life. And I think for a lot of people, it's definitely unwanted because it's some fear of the unknown. We all were raised and, well, I'm not gonna say we all, But a lot of us were raised in different Bibles, where our Bibles that were written by man pretty much dictates our perception of what death will be like. When in actuality, my personal opinion is, hey, I never met anybody personally where I can say this person has died, this person has experienced everything that's going to happen when a person actually expires. I haven't met them. So I think that the dying process and what actually occurs after an individual is dead, we really don't know what's going to happen until we actually die. But we do have faith that whatever we were taught in those Bibles, that's true, that those things are true. But when I took a political science class in college, the political science class changed up my view on religion. It switched up my view on religion because of the simple fact. It's like, no, this stuff was written by man. Now, that's a lot of stuff that do make sense in the Bibles. I think if you follow the Bibles, you have chances of living a longer life. But a lot of things had to be created to control the world. It was too many people and too many different behaviors in the world. So many things had to be created. The Bible had to be created to instill some fear in man, in which I'm not saying the entire Bible is not true. Prisons had to be created to control man. So many things have to be created in order to control man. I'm pressing mute really quick because this is Ms. Lee calling so I can get a response. As for y'all test and everything else. And it just points out Warden's 4 tasks of mourning. And the 4 tasks of mourning is to accept the reality of the loss, experience the pain of grief, adjust to an environment without the deceased, if the loss is a deceased loved one, and create an enduring connection to the deceased loved one while embarking on a new life. And it's common grief reactions. Some of the reactions to for grief is shock, anger, anxiety, numbness, denial, guilt, sadness, relief, depression. And we know with anxiety can lead an individual to the hospital. Because some forms of anxiety is considered natural, to have stage fright, because you're about to perform in front of a bunch of people or give a speech in front of a bunch of people. You kind of a little sweaty, you start to sweat, getting a little nervous. That's natural, but when it comes to a point that anxiety have you experiencing a panic attack, you might have to be hospitalized. Not anxiety, when you are experiencing grief and is leading to depression, individual may need to be hospitalized. They may need to see a psychiatrist or something. Because depression, being depressed, that also can lead to suicide. I'm so depressed because my support system did not. My wife did that. She was the breadwinner. She made sure I lived good. She made sure I had everything. All I had. Individual become depressed. Individual become suicidal. Those types of things. And it's really important. One of the ways that I kind of think, and before I started nursing school, my thinking was like, you need to do what you have to do for yourself and have the attitude that if your support system disappears on you, where you gonna be at? Because our support systems can leave in multiple ways, be it death, be it to a point that they just want to disappear from us. Your support system can leave you. So it's really important to always come up with ideas to make sure that you're okay, because, families are killed. The family of 5 can be in a car together where that's your whole support system and get in a car accident. And now you have no one. So it's really important to look at life as if everything could just disappear and try to create a foundation. And it talks about the age of the person experiencing the grief will influence the grief response. One of the things that I experienced a friend of mine getting killed. And when I experienced my friend getting killed, I got the phone call while I was at home. I was like cooking, I was frying chicken, I was making like beans and things like that. And I was about to be real dramatic when I got the phone call, like run off, hollering, crying, those types of things. But it was like when I was in the process of doing that, I got real dramatic while I was on the phone or whatever, like reality snapped in. It was like, you got food on the stove. You have food on the stove. You you need to go tend to your food. You need to tend to your food. And part of that message is, I think that was a moment where I learned to tolerate death a little bit different. Where it's like, regardless of who passed or who expired, you still have to live. You still have to live. You know, some people go through death where I'm gonna call off work for the next 2 weeks and then be angry when they don't have a check and they can't pay their bills. It's like, nope, somebody died, but you still have to live. You have to live. When it talks about religious and spiritual rituals can help a person who is grieving to deal with death and the grieving process. So sometimes just having a support system, church can be your support system, where you have somebody or some people where you can express yourself to. You can express, hey, this is what I'm feeling right now. You know, it can actually help the grieving process. And it just talks about some responsibilities of the nurse when an individual is experiencing grief. And as a nurse, we want to be there to actually to be some support for the patient, to be a listening ear. We want to be a listening ear for the individual who is actually experiencing grief. We want to give therapeutic rub, and therapeutic rub sometimes can be just that warm touch to the back where you're able to rub that individual's shoulder, where that is therapeutic rub. We want to be understanding. We do not want to offer any false hope. And offering false hope is saying, hey, stop crying. You know your mother in a better place. No, we don't know that. We don't know that. So we're not about to offer false hope. Okay? And we just want to be supportive, because some people may actually need resources to actually help them with burying their loved ones, those types of things. You want to refer them to the social worker. That's more so the social worker responsibility in the nursing homes as well as in the hospital settings, where the social worker will help the patients or the patient family to get resources that may actually benefit them with the grieving process, and that may actually benefit them as it relates to expenses. And will somebody read this?
Nurses may experience grief after a client's death. Reactions differ among nurses in expressing grief and is affected by the clinical circumstances of the client's death, as well as personal factors specific to the nurse. Because reactions differ, each nurse needs to be aware of and manage their grief.
Yep, and nurses do get so emotional that they cry when some of their favorite patients expire or whatever, because working in a nursing home setting, you all will more so, y'all will have some long-term care patients, and them long-term care patients, they are there for long-term care. That's their home. They live there, and ideally they would die there. So you all will experience death as nurses. And some of it, sometimes y'all will cry. The facility I was a director of nursing at, I was a DON before I actually resigned as a director of nursing in May from the facility I was at. But we had a patient who expired. He'd been at the facility for some years, and a lot of the staff were crying. So a lot of the staff were crying, so we had to get social services involved. So this module was talking about end-of-life care. Okay. And when somebody reads, well, actually, you don't have to read it. It talks about hospice care. So with hospice care is offered to patients who are terminally ill, where a patient has less than 6 months to live. They're typically a candidate for hospice. And hospice care focuses on more so managing a patient pain and managing some of those signs and symptoms of death. With hospice care, the goal is to eliminate curative care. If you are still searching for a cure and you want to be cured for whatever you are going through, hospice care wouldn't be appropriate for you. Hospice care is end-of-life care. And it talks about palliative care. Are you all familiar with palliative care?
Yes.
So discuss palliative care, Sharmisha.
So palliative care is basically when a patient is near end of life, you are no longer trying to cure them. You are just trying to keep them comfortable and support them in their transition from like life to death.
Yeah, but sometimes it don't always have to be deal with end of life, but palliative care is a way to keep a person as comfortable as possible. Maybe you are approaching death. Maybe you have a tumor. And with this tumor that you have, maybe doctors are like, hey, eventually this tumor gonna kill you or whatever. But what we can do to kind of alleviate some of your discomfort with breathing because of the location, we can do radiation to shrink it some. And with us doing radiation, it'll make you breathe a little better. That's palliative care. Palliative care is comfort care. This care that we about to give you is to make you a little bit more comfortable. Maybe it's to a point that you have some damage going with your intestines. Palliative care is saying, hey, you know, opposed to you continuing with that damage, how about we give you a colostomy bag to give your intestines some rest so that they can actually heal. So palliative care is more so comfort care. We're gonna put these different interventions into place so that you will be as comfortable as possible. And palliative care and hospice care is different because with hospice care is offered to an individual with terminal illness who should be ideally, they have a life expectancy of 6 months. Within 6 months, this individual it's planned for that individual to actually expire. And hospice care is not curative care. Palliative care is just comfort care. The care we're going to give you is to try to make you a little bit more comfortable.
So a patient can be on palliative care for an extended amount of time, but if you're on hospice, it means you have like 6 months or less to live?
Correct. And of course, some people outlive that 6 months. Some hospice patients outlive that 6 months, where some of them end up living for 2 additional years. That type of thing. But ideally, a hospice patient is expected for them, if the criteria to be a hospice patient got to have some type of documentation stating that they would die within 6 months. And there's also some other things that make patients a candidate for hospice. So I want to say most of the time, that's what the school book teach. School book more so teach within 6 months is expected for a patient to expire, but there's some other things that qualify patients for hospice. And it talks about the physiological changes that occur with end of life. And with dealing with patients who are actively dying, you will see changes in their breathing. where patients may experience dyspnea, difficulty in breathing. You also may hear a rattling sound for a patient who's actively dying, and that is considered death rattle. When you hear death rattle, that's pretty much the message that death is imminent, that this patient is about to go. And we do have medication for death rattle where it actually stops the rattling sound. Shane Stokes respirations. It's irregular, and it's where a person will breathe really quick, breathe really fast, and then they will completely stop breathing. And then start back breathing really quick, breathing really fast, and then they will experience apnea again. So they have moments of quick breathing and periods of apnea. And we know when we're looking at these words, apnea, these words with the A in front of it, typically means no. Apnea is no breathing. And it talks about,
I have a quick question. So like, when they're near death, I know a lot of times they start to administer morphine. What is the purpose of that? Because I know it's supposed to be a pain medicine. So are they in pain? Or I always wanted to know, because when you hear morphine, it's like, oh shoot, it's about to happen.
So the morphine is being administered so they won't have a painful death. Because that's the reason. Like, I always been one of the people where I'm like extra nosy when it come down to somebody dying. And back in the day, my friends didn't get it. Like, my friends, like, I just can't believe you always asking about somebody's death, how this person died, how long it take him to die, and this and that. And it was kind of like, you know, a child, I'm working my way to be a nurse. Okay. So
yeah, yes, I'm the same way though.
Okay. I want to know about death. I want to know how this person died. I want to know how they looked. I wanted to know all of that. What was the purpose of me saying that? But with a lot of deaths, a lot of the patients do experience pain, and especially cancer death. And it talks about it right here. Pain experienced by nearly 60% of older adults, hospice clients with cancer. I seen one of my friends dad where he was actively dying from liver cancer. And I'm trying to tell you, that man was in pain. He was in pain. You know, so death can, depending on how an individual is dying, pain can actually occur with it. So that's the reason the morphine is actually administered. And sometimes the patients are breathing hard, because one of the things we know about morphine is that morphine can slow down the vital signs.
Okay, that makes sense. Okay.
So for a patient who's breathing hard, the morphine actually slow down the body processes too. A patient who's breathing hard, sometimes the doctor may say, well, get them a dose of their morphine. That will slow their breathing down, that type of thing. And that's why some people don't like giving their loved ones who are actively dying morphine, because they are fearful that it's going to stop mama from breathing. It's going to stop grandma from breathing if we keep giving her this morphine, because morphine will slow the body down. So a patient and that will be important, because as future nurses, when you have patients where I'm thinking about non-hospice patients, you have patients who have an order for morphine. And one of the things you learn about morphine is that, hey, morphine do slow the body down. And you have a patient who's breathing at 10 breaths per minute, but they also asking, hey, nurse, I want some more of my morphine. And it's like, you know, hey, patient, I'm not giving you this morphine and you breathing at 10 breaths per minute, because it can potentially kill you. Okay. And you report it to the physician. And it talks about the temperature. When the patient is actively dying, there are multiple things that you will actually see and observe. You have patients who are actively dying where their hands, their lower extremities, they start to be cool to touch. The patient begins to perspire where their skin is really moist. And some of them start looking like clay. They start looking like clay. Then you have, and it was funny, who was I just talking to? I was just talking to one of my friends, because his grandmother just expired like 2 weeks ago, and he was explaining to me yesterday He like, you know, when my dead wife found my grandmother expired, all my dead wife was talking about was how he was saying his grandma, she had a tear in one of her eyes. And the wife interpretation was, you know, she was crying because she didn't want to go. And what I had to explain to him was when patients are actively dying, patients have a fixed gaze. They have a fixed gaze where their eyes, when you look at them, they staring at that one little fly on the wall. And their eyes don't move. They staring at that one fly on the wall where them eyes are bucked open. So what end up occurring is your eye become irritated. Your eye is irritated because all I'm doing, my eyes is bucked. I got a fixed gaze and I'm staring at that one flat on the wall. Your eyes get irritated and they water and tears fall. So some people interpretation is the individual is sitting there crying. Science interpretation of that is no, that individual eyes are irritated. So yes, they are dropping tears. And it just talks about some other changes with death. Typically, they actually say hearing is the last thing to leave when a patient is actively dying. And that's why it's important when you are providing care for your patients who are unconscious, when you are providing care for your patients who are actively dying, you need to communicate with them as if they are alive. You need to tell them everything you're doing. Ms. Rogers, it's me. I'm here. I'm about to give you a bed bath. Or Ms. Rogers, I'm about to give you some morphine. I see that you appear to be in pain. Where you constantly talking to those patients. And it talks about clients may experience hallucination. And the way them hallucinations go is that they seeing people who are actively dead. I had a patient when I was a nurse assistant. Her name was Miss Moss. And while she was on her, before she was on her deathbed, me and her used to always communicate. She always told me about her family. All my sisters are dead or whatever. And one of her sisters' names I still remember, her name was Hazel or whatever. And I can't think of her other sister name right now. But Miss Moss would express herself to me, you know, all my sisters dead, I'm the only sister living, etc. That type of thing. But when Miss Moss was on her deathbed, I remember picking up a midnight shift and I went in her room and she like, tell my sister to stop playing with me. I'm like, what? She like, tell my sister Hazel to stop playing with me. She behind the door or whatever. So she got to calling out a lot of her dead loved ones. And by me being around her for so long, I knew who the loved ones were, who she was telling me were dead. But at that moment, while she was actively dying, she got to seeing all her dead loved ones. And she was communicating with them too. And that's why some stuff is so amazing because it's like, was she actually experiencing a hallucination or were her dead loved ones actually there with her? Because I have had multiple people who were actively dying who have told me that they dead loved ones have come to see them. My aunt, before she died, she went to she never really was the aunt to go to church. She was considered the angry auntie, the mean auntie. She don't go to church, that type of thing. She ended up going to church one Sunday. And the month that she went to church, my uncle was killed months prior. And her message to the family when she left church, she telling everybody, yeah, telling my grandma, I saw your son in the church or whatever, telling us I saw your uncle in the church. And we know our uncle and my grandma's son, he's dead. So the family interpretation is, well, hey, he's happy that you finally went to church. That's why you saw him. He happy you went to church. And her interpretation was, no, he was introducing me to my death. That's what her interpretation was. And her interpretation was right. And I actually seen her go through the different stages of grief. And it wasn't to the point with my auntie where she went to the hospital and they told her she was about to die, but she just knew in her heart that she was about to die after she saw my uncle in that church. She was adamant about it. Where the family was adamant, hey, he's happy you at church. She was adamant, no, he introduced me to my death. And I remember her telling my auntie, she like, I talked to God and I told God to let me live for your birthday party or whatever. And then he can take me if he gonna take me. And that's exactly what occurred. She went to my auntie birthday party, and after she left my auntie birthday party, she fell out and had a massive heart attack on her porch, and she died there. So some people do know when they are about to die. And some people actually say, hey, them loved ones come to see them before they actually expire. So that's why I say some stuff is real confusing and real iffy. And it just talks about dignity. Make sure that you are offering all patients dignified care. Your patients who are alert and oriented, your patients who are unconscious, your patients who are bedbound, make sure you are offering them all dignified care. And typically when a patient is actively dying, we don't want to do too much. We don't want to do too much. We don't really want to have to get them shots. We don't really want to have to keep checking their vital signs because that stuff is painful for them. So we want to try to keep them as comfortable and as clean as possible. If you're providing care for a patient who's actively dying, what position should you have them in when you are providing mouth care? Hello?
You said mouth care?
Is it in a 30-degree angle?
Yeah, you definitely want to have a head of their bed elevated if you're providing mouth care, or if you provide mouth care using mouth swabs. You want to kind of turn their head to the side so that they won't aspirate on fluids, those types of things. And you want to keep the patient as comfortable as possible. When I talk about post-mortem care, post-mortem is after death, the care that the patient will receive after they actually expire. Typically, in a nursing home setting, the certified nurse assistant is responsible for giving that patient a bed bath, cleaning the patient up, putting the patient on whatever clothes that the family want the patient on, or just putting the patient on a gown so that the body can be transported by the funeral home. Typically, in a nursing home, the funeral home will actually come get the patient body from the funeral home. And we definitely, when a patient expires, you need to contact the physician. You need to contact the guardian if the patient have a guardian, or you need to contact their emergency contacts to notify them to come to the facility. The patient have expired. Patient body should be out the facility within 4 hours. So if loved ones do want to come see the expired patient, they have up to 4 hours from the patient's death to actually see the expired patient. And as a nurse, the nurse, when the patient expires, is responsible for removing tubing. The patient got a urinary catheter, you need to remove it. Patient got IV lines, you need to move it, remove them, those types of things. You want the patient to appear as comfortable as possible. Make sure the patient's eyes are closed. You want to lift their chin up, maybe wrap a towel up, put it up under that patient's chin who's actually actively dying. Is there some other things I want to point out?
Isn't there,
I have
if
a
they have
question after you're done.
sorry, if they have an autopsy, don't you have to keep the tubes in?
So in some events, that's true. In some events, all equipment will be required to remain in the patient body if they actually expire. So that's definitely true. Because I have had a patient who she was on a blood thinner and she fell and bled in her brain. And I was told, hey, once she died, you have to call a coroner. You cannot touch her body. And that was in a hospital setting. You cannot do anything to her body other than clean her up, make sure all equipment remain in her body, those types of things. So in some events, all equipment do have to remain in the individual's body. But in a nursing home setting, I don't think I ever experienced that, where the equipment had to remain in the patient body. But hospital setting, I have experienced that a few times. And in a hospital setting, if you all are nurses in a hospital setting, typically the patient care tech will clean up the body. You will remove all the equipment, and the patient care tech will be responsible for putting that patient body in a body bag and taking it to the hospital's morgue. Typically, all hospitals have a morgue.
So my question is, because I've done post-mortem care, my question is, so as delegating as an LPN, if you worked in a hospital setting, I know as a patient care tech, we removed catheters and stuff like that. Now in nursing homes, the CNAs do not?
They don't. Patient
Okay.
care techs are more skilled. So patient care techs are trained to insert catheters. So depending on where the patient care techs work at in the hospital is what dictates the different things they would be responsible for. Because when I worked in a hospital, to me, our patient care techs were complete CNAs or whatever, where they did nothing but CNA work. But other units in a hospital, the patient care techs function within their scope of practice, where you about to insert a catheter, you about to remove it, you about to go draw this blood, those type of things. So patient care techs come with a skill that some nurses don't have. You know, nurses are not trained to draw blood. Patient care techs know how to draw blood. You know, so with some things that a patient care tech, a knowledge base that they have, the nurses don't have. The patient care techs in a hospital, different things can be delegated to them. CNAs, no. And that's why it's good too, if you all are have worked as CNAs, so you can kind of know, hey, this is what I was allowed to do, so this is what CNAs are allowed to do. Because one of the things that we never do is have anybody to do a job task that is not within their scope of practice, or that they haven't been trained to do that actual task. Will somebody read this page, organ tissue donation?
As organ and tissue donation is, hold on, my screen. As organ and tissue donation is voluntary, the donor must give authorization before death, or a surrogate can give permission when the client has not previously consented. A nurse is not allowed to begin a dialogue about organ or tissue donation with the client or a family member. Only healthcare professionals who have a completed course provided or endorsed by an organ procurement organization, OPO, are permitted to initiate the request of the client or surrogate. The nurse's role is to assist families who are dealing with this challenging decision.
Okay. What, it was something else I wanted to point out to you all. So this module is talking about the surgical client. And it talks about the 3 perioperative phases. And the 3 perioperative phases is the preoperative phase, the intraoperative phase, and the post-operative phase. What is the preoperative phase?
Like before surgery?
It's before surgery. And what do intra mean?
During?
During. So intraoperative would be the phase during surgery. And post-operative, what do post-operative mean?
After surgery?
It's after surgery. So you all want to be clear. Pre mean before something, post mean after something. And anytime a patient is about to have a surgery, because some surgeries are selective surgeries, some surgeries are emergency surgeries. During the preoperative phase, what do you all feel like will occur during the preoperative phase? Physicians know, nurses know this patient about to have surgery or whatever. What will actually occur?
Vital signs, maybe maybe like some testing, or
They're gonna get them IV fluids and stuff like that.
They're going to be made
Preoperative
NPO right
basically.
away.
Okay, so y'all just said everybody type in the chat 2 things that will occur during the preoperative phase. 2 things that will occur during the preoperative, and type it all at once. 2 things that will occur during the intraoperative phase, and 2 things that will occur during the post-operative phase. I'm gonna give y'all 2 minutes to do each one of those. Okay, so with the preoperative phase, the preoperative phase is actually before whatever surgical procedure the patient has to receive. So some of the things that I can think that the patient will require education. Patient need to be educated about the surgery. They will actually receive, the person who will educate them about the surgery will be the person who's doing the surgery. You got to get a knee replacement. The surgeon needs to be explaining how the knee replacement will actually occur. Consents need to be signed. The nurse needs to ensure that the consents are signed. In the event a patient express, hey, I don't understand what I'm getting the surgery for, the nurse needs to be notifying the surgeon. So the surgeon can come back and explain to the patient.
First rapper to get the white robe, and then
during the preoperative phase, patient need baseline vital signs. Baseline vital signs. We need some baseline lab work. We need to actually see how your labs look. Do you have enough red blood cells? How's your PT and INR? A lot of education have to occur. We need to know what your diet is. You may have to switch up your diet. You have to be educated if you when you need to be NPO for the surgical process. Intraoperative pay, during the intraoperative phase, that's where the surgery is actually occurring, where you definitely want to get the patient prepared for the surgery. During the surgery, we have to maintain aseptic technique. The nurse will be responsible during surgery to reposition the patient, prevent different things from occurring, such as aspirating, making sure suction equipment is present in an event that you have to suction a patient to prevent them from aspirating. Post-operative phase is more so after the surgery, monitoring the patient vital signs for a particular time, monitoring the incisional site. The incisional site, patient should not be bleeding heavily. If it's to a point the patient is bleeding heavily, you want to report that to the physician, report it to the surgeon. Post-operative phase, making sure if the patient is on a specialized diet, that diet is being enforced. And those are some of the things you need to do during those different perioperative phases. And you also need to, during the post-operative phase, check whatever system that's been affected by the surgery. That system you need to be monitoring. If a patient got a knee surgery, part of your responsibility, and when it comes down to like checking pulse sites, you want to check all distal pulse sites. Patient had a surgery on an upper arm, we need to be checking distal pulse sites to ensure circulation is occurring. And what will be the distal pulse sites from the upper arm?
You said distal from the upper arm?
Brachial or the
Brachial or radial?
The brachial and radial pulse. And if a patient had a surgery along the femoral artery, what pulse sites are you responsible for checking?
The
popliteal,
yeah, that's what it's called.
dorsal pedius,
And it's another one.
the pedius, pedalis.
The tibia.
The tibial pulse. Yeah, you want to check distal pulse sites. Whenever a patient has a surgery on a particular area, you should be checking distal pulse sites. And what should you be checking those distal pulse sites for?
Like circulation.
Circulation. We want to make sure we checking for circulation, that we palpating those pulse sites bilaterally. We want to make sure that we are looking at the skin integrity. Do we see any changes in color? Are the patient legs turning blue following a femoral artery replacement or something? Is it to the point that the patient legs are beginning to be cool to touch? Those are things that need to be reported to the physician and the surgeon. And it also points out some preoperative assessments And the preoperative assessments is getting client history. We want to know your medical diagnosis. We want to know your chief complaint, what brought you here. And that's a good question to ask your patients in a hospital setting. Hey, what brought you here? Where it gives them an opportunity to answer an open-ended question. Okay. And allergies are huge. That is something that patients should be assessed for on day one, whether or not they actually have allergies. And if a patient say they have allergies, it needs to be documented. And sometimes it can be some of the simplest stuff. I got allergy to strawberries. And it's like, okay, what do the strawberries? They make me nauseated. Well, then that needs to be documented. Patient have allergies to strawberries. It needs to be documented. And sometimes patients have allergies to medications and a doctor will still give it. I didn't have, when I first became a nurse, that's why like some stuff you definitely would be in the learning phase. Because I'm thinking like, okay, if you got an allergy, we dang sure ain't giving you that. But sometimes doctors will still give it to you because the benefit outweighs the risk. The benefit it outweighs the risk, where hey, it will benefit you more to receive this medication even though you have an allergy to it. But what we are going to do, since we know you have an allergy to it, we're going to give you Benadryl 30 minutes before we give you this medication. And after that 30 minutes, we're going to give you that medication. So sometimes patients with allergies, the physician will still give them whatever they're allergic to. And people can have allergies to multiple things, foods, medications, etc. Some people have a lot of allergies. And some people who do have a lot of allergies, especially, hey, you had allergies since you was a baby or whatever, sometimes it's due to a child receiving animal milk too early, where children should not receive milk from an animal until they are 1 year old. That's when they actually can start drinking whole milk. Kids who actually receive animal milk from an animal before they're 1 year old, they typically have a lot of allergies. And it just talks about smoking. For our smokers, when you know a patient smokes, they need to be educated about that they need to quit smoking. They need to stop smoking before the actual surgery, because the smoking, it actually can compromise their respiratory system. It can make it a little bit more challenging for them to heal at a quicker pace, and it can cause complications during surgery. And it just talks about a pregnancy test should be given to women of childbearing age if the menstrual period is more than 3 to 4 weeks, or upon the client's request. If the client refuses, it is their right to do so, and this should be documented. Anytime a patient have a right to refuse any care. Patients do have a right to refuse care, and our role in the event that they are refusing care is to actually document. And what I want to document, if my patient is refusing care, I want to document that this patient was educated about the need for whatever care they were refusing. If they refuse the meds, I'm documenting patient refused their medication, writer educated patient about the need for the medication, writer educated individual about possible risk of refusing medication. If this individual have a guardian, I want to document that guardian was notified, physician was notified, and physician did not give any new orders.
Mr. Williams?
Yes.
You know how like if someone is in a facility or at the hospital and they leave like against medical advice, you had them sign an AMA form? So
yes.
What if the person refused to do that? What if they be like, I'm not signing that, and they still like, how do you cover your, cover your butt?
With documentation, and I will also probably ask another nurse to offer that patient to sign a AMA document to see if that nurse can get better results than what I did. And if that nurse, the patient still refused to sign, that other nurse, I will ask them to document as a witness as well. So your documentation is what more so covers you. Because some patients won't sign it. Some of the patients be angry and they be adamant about leaving. When they say they're ready to bust up, they're ready to bust up. And you have different patients who would do that, especially like drug seekers. Just to say, if I was in a hospital, they transferred me to a nursing home. Today, the 1st of the month, I got my check. Oh no, I don't want to be in that nursing home. I'm getting the hell up out of here. And they will try to bust up. But if a patient do not have rights over themselves and they have a guardian, oh, you can't sign no AMA paper. That would be your guardian who will have to come here to sign that or whatever. And if that patient was trying to leave, then we're going to call the police on you, or we're going to petition you to the hospital if you become combative because we're not letting you leave the facility.
Because that happened to me one night. I was at work. I went to draw somebody blood, and they got, like, I guess they had a previous conversation with their nurse. So when I got there to draw their blood, they was like, "Oh no, I'm leaving. That y'all ain't poking me with another needle." And I was so confused. I did not know what was going on, and they just left. And the nurse came, was like, "Where did they go?" I was like, "I don't know. He just left."
Okay. Yeah. And it just talks about informed consent. Somebody can actually read this information, please.
A client's full understanding and choice to have a treatment or procedure, including the risk, involved benefits, and other alternatives available, as well as the benefits and risks in lieu of having the treatment or procedure. The client must be aware of what the treatment or procedure is, who will perform the treatment or procedure, the purpose, and the expected outcome.
Okay. And it's just the preoperative education. It's talking about preoperative education. Before any operation, a patient requires education. We need to make sure that they educated, that they understand the surgical procedure. They will actually receive. Patients have a lot of questions before surgery. Am I going to be in any pain? What y'all going to do about my pain? How I'm going to feel? Am I going to be able to move around after my surgery? Well, they require all that education. You need to educate the patient. If it's a procedure where this patient is about to be on bed rest after the surgery, you want to inform them. We do not lie to our patients. I done worked with healthcare workers who tell him anything or just tell him. And I remember having a student, because I taught in the patient care tech program as well, where we had a patient, he was extra anxious. He was really anxious or whatever. His heart rate was like 120, somewhere around there. And I overhear the student talking about, she announced his heart rate. And and I told him his heart rate was normal because ain't nobody got time to be, that type of thing. Oh no, I went off on her. Because what we're not going to be doing is lying to patients. And I don't care if it's to a point where, hey, this patient is going to be upset. This patient going to be this. No, we're not going to be lying to patients. We're going to be as honest as possible. And if it's to a point that we need to have other healthcare providers in a room with us after we share some information with a patient, then that's what we need to do. But we're not going to sit and lie to patients because we do not want to create that type of system. Because there's already people who don't trust nurses, they don't trust CNAs, they don't trust doctors, and that's the reason why some people don't go to the hospital. I don't want y'all all up in my business. I don't want y'all telling my business, or I don't trust y'all because y'all all are liars. Those types of things. We want to create an environment where patients can trust. We want to create an environment where we are honest to our patients. Where we're nothing but honest to our patients, because we build in relationships. And if we create a system where we know I lie to my patients all the time, I tell them whatever they want to hear, that's going to make us not trust the system. When it's our turn to actually go to a hospital, we're not going to trust them. And it talks about wound dehiscence. What is wound dehiscence? We talked about that last week.
When a surgical incision opens back up.
Yes. that surgical incision opens back up. What are some ways to prevent wound dehiscence?
Covering it with clean gauze, or
You say what?
covering it with the sterile clean gauze.
My question is, what are ways to prevent wound dehiscence?
To prevent it from opening.
Help the patient, like when they're trying to get up and move, or like if they're trying to, do anything.
Yeah, in some situations, if the patient do require help, you do want to assist them. Because some surgeries, patient can walk around on their own or whatever. They're able to freely ambulate after the surgery. Because most surgeries, if it's not to a point that you have to be immobilized, we want you to get up and we want you to start walking around. And that's to prevent you from getting blood clots. So to prevent a wound from actually opening up, we want the patient to splint. If you had a cough, you need to put a pillow over your abdomen and splint. I mean, to use that as a splint. We do not want you picking up any heavy items. We don't want you doing anything strenuous because we do not want that wound to split open. Do not strain while you're using the bathroom. We don't want you doing too much pushing or too much straining. And the circulating nurse, will somebody read this?
Coordinates the care, oh, hold on, let me move my screen. Coordinates the care of the client before, during, and after the surgical procedure, responsible for verifying consent forms, provides emotional support, and assists the anesthesiologist as needed while anesthesia is initiated. Responsible for client safety, positioning, and monitoring, as well as enforcing policies and procedures during surgery, including the timeouts. Maintains sterility, provides supplies and equipment to the sterile team, documents the care given along with ensuring the specimens utilized for surgery are labeled correctly and positioned in the appropriate media. Along with the scrub tech, confirms counting of the sponges, instruments, and sharps used in the surgery.
Okay. This just talks about the scrub nurse, also can be called the instrument nurse, where this nurse is responsible for making sure that the surgical room is sterile. That the utensils are sterile and ready to actually use, because in a surgical room, it has to be completely germ-free. The goal is for it to be completely germ-free so that no germs will be introduced to the inside the patient body. And typically the scrub nurse is typically the nurse who passed the physician or the surgeon the different instruments that will actually be needed for the surgery. And it talks about anesthesia. And anesthesia can be localized. You can receive localized anesthesia. You can receive anesthesia that's considered generalized anesthesia. With anesthesia is kind of like it works as a nerve block. It works as a nerve block. So with anesthesia, if you are receiving it locally, it's probably for some type of minor surgery. Some type of minor surgery to actually prevent you from actually feeling exactly what's occurring. Although you kind of can feel some of the movement if it's local, because local anesthesia, the individual will be woke for it. You will be woke for local anesthesia. Women who tend to get cesarean sections, C-sections, most of the time the physician wants them woke. They want them woke because if they put them to sleep, giving them generalized anesthesia, it can actually affect the baby's respiration. So local anesthesia is given for localized areas where it will work to cut off the sensory nerves, where it works as a nerve block. Regional anesthesia, it actually causes temporary loss or feeling in an area of the body. Generalized anesthesia, it will actually put an individual to sleep and Some people receive conscious sedation, and it permits the client to remain relaxed and calm so that they can follow commands without pain or anxiety. And this is probably what they will give a woman who's having a cesarean, moderate or conscious sedation, regional anesthesia, local anesthesia. When I actually was in nursing school, I witnessed a lady who had to have a emergency C-section, and she was like arguing with the physician because the doctor she had, he was 93 years old. He was 93, but she was arguing with him, put me to sleep, put me the fuck to sleep, or whatever, because she was actually my patient, and she was in labor, and the plan was for her to have a natural birth, and that was her first child. But I think the baby cord was wrapped around his neck, something like that, where they like, she about to have an emergency C-section. Oh, she flipped out. She flipped out because she was scared. She didn't expect to have an emergency C-section. She was had hopes that I'm about to have this baby naturally. Those types of things. Oh, she nutted up because she was completely scared. And when the doctor told her, we're not putting you to sleep, you staying up for this, or whatever. Oh, she really nutted up. And one of the ladies who I was in clinical with, to me, she was like the best to that young lady who had to deliver. I just felt like she gave her great support, and I like loved that she was like holding her hand, she was rubbing her head, where I just loved everything that she actually did as a student nurse. And it just talks about surgical risk factors, some of the things that actually can contribute to unwanted outcomes. Being older places individuals at higher risk for different complications. Having poor nutritional status, where individual don't eat the appropriate foods. Maybe individual are eating foods that are bad in fats, or eating foods that are contraindicated, or even with surgical risk factors, a person diet can increase their risk of different complications. And even being obese actually increase risk to different complications. Where following a surgery, it may actually cause you to have breathing issues. You might have some issues with breathing following your surgery. So it's multiple things that can actually affect the patient. You know, some of the surgical risk factors is patient can get an infection. If aseptic technique is not used throughout the surgery, patient is at risk for an infection. And if I just had a surgery today, when should you start monitoring me for infection?
Immediately.
So
right?
if I had an infection today, if I just had a surgery today, what is the appropriate thing to say? So just to say, with any infection, if you just came in contact with the germ today, are you going to immediately see signs and symptoms of an infection?
Oh,
No,
no.
doesn't it take like a day?
Probably first 24 to 48 hours.
Maybe after, probably like within 48 hours or longer. Or
Is that why they tell you to come like have a post-op appointment after you had surgery? Like my son had surgery, then he had to go to the doctor 3 days later so they could look at his incision.
Yeah, sometimes they definitely will do that or whatever, where you need to actually come back for follow-up care or follow-up assessment. So yeah, but typically infection will show up about 3 days later, 3 days or longer. You will start seeing signs and symptoms of an infection, because when you all are answering test questions, and those test questions are saying patient it's 4 hours post-op. What's the nurse's biggest concern? Well, it wouldn't be checked for infection. Patient 4 hours post-op, my biggest concern is not checking for infection, for the simple fact signs and symptoms of an infection not going to show up until like three days or longer, when I would start seeing signs and symptoms of infection. But my main concerns would probably be patient vital signs. Let's check this patient vital signs, because the vital signs are an indicator of health status. If patient is bleeding out internally, that's just showing a blood pressure. That should show on a heart rate. That should show on a temperature. Because with internal and external hemorrhage, what makes them two different?
Well, external, you can see it. Internal, you won't necessarily be able to see it. They may have some pain, but you won't necessarily be able to see it. Like you said, you'll be able to tell from the vital signs.
Would the internal ones like be like from the organs?
Internal hemorrhaging is where you are bleeding inside of your body. External hemorrhaging is where we actually can see the blood.
Right, I was gonna say the same thing Sean said, because you can actually see it, and internal you can't see, and you will have to go by. Yeah, I mean, yeah, you have to go by vital signs to show the signs and symptoms.
So internal hemorrhaging, you can see it. If I'm bleeding right now internally in my abdomen, it will be to the point where my abdomen start getting darker in that area. It would be to a point where you starting to recognize it look like fluid is accumulating in your abdominal area. So you will start seeing the fluid accumulation. You will see changes in color in that particular area. So you can physically see signs that maybe this patient is experiencing internal bleeding, but of course, vital signs will be an indicator of that as well.
Can they feel there's a pain in that area?
You said what?
Can they have pain? Do they have pain in that area where the blood is pooling, due to
sometimes
internal bleeding?
They can possibly experience some pain in that particular area. Okay. Yeah. And it talks about the indications of complications. So following the surgery, patient experienced nausea and vomiting. That can be an indication that something is going wrong. Patient experiencing some type of cognitive deficit. Patient has clots, where patient have a pulmonary embolism, and that'll be a clot in the lungs. And the way I would probably realize that is where this patient is complaining of changes with their breathing, or you you observe that, hey, you breathing different. You are breathing different, and you need to respond. Hypotension or hypovolemia, which can be a sign that this patient is hemorrhaging, you losing blood. Atelectasis will be the collapse of the alveoli that's in the lungs. So now that's about to affect gas exchange. Wound infection, we expect to see a wound infection some days later. Wound dehiscence, that wound is split open. And it talks about an ileus. Ileus tend to occur after surgeries, and that's where the iliac region of the intestines, and typically it paralyzes. It's not functioning. A patient experiences a paralytic ileus along the intestines, and the way that a nurse can actually figure that out is by auscultating. I'm listening to your abdominal sounds, and this particular area, your bowel sounds are absent, which can be a sign of a paralytic ileus. And oligria is where the patient is making bare minimum urine. So following surgery, we need to be monitoring urinary output. What is the normal range for urinary output per hour?
30 to 50.
30 to 50 mLs per hour will be considered correct. And it talks about the patient control analgesia pump. It's pretty much a pump where they are able to get pain medication, and connected to that pump is a button where they can just press that button every time they need something for pain, where they don't have to contact the nurse, give me something for pain. You got this pump that's connected to your IV. Every time you push that button, you can get something for pain. But it is limits set on that, where, hey, you ain't getting this much. You can't get no more than this, that type of thing. But patient control analgesia pump give the patient an opportunity to be as independent as possible. Yeah. And it just talks about safety considerations for the surgical client, being able to realize when your client is considered a fall risk following a surgery, following different the administration of different medications, knowing when your patient is at risk for aspirating, how to prevent aspiration, and how to prevent aspiration is proper positioning, making sure patient is in a proper position. If patient received generalized anesthesia, making sure that this patient has their gag reflex before actually giving them something to eat or drink, making sure that appropriate precautions are in place. If your patient is a fall risk, making sure fall precautions are in place, monitoring your patients for cognition changes. Okay.